I'm here today with Dr. Jim Horowitz. Jim serves as director of the ICU at New York University. Jim, thank you for joining us. We're actually here today at ACC, the ACC meeting in New Orleans, and one of the big topics, part of the big buzz, is high-risk PE at a cardiology meeting. So tell me a bit about your team's approach to currently high-risk PE at NYU.
Yeah, thank you for inviting me here. I think this is super exciting. I'll tell you that, when Inari reached out to me, when Tom reached out to me 3 years ago about this trial, I was ecstatic because submassive PE is a bear to study. But high-risk PE, massive PE, patients, the risk of death with a single occurrence of PE is in 35 to 45%, depending on who you ask. So these are highly morbid, highly mortal patients. So there's a huge space to intervene early. And so I think that's why this discussion or this research has been so powerful, is that we're looking to really contribute to how we can take care of these patients.
Mm-hmm. Now, the FLAME registry, as it's structured, is a multi-center, concurrently enrolling registry. It had treatment with FlowTriever for patients specifically with high-risk PE, also enrolled a context arm. Tell us a little bit about the trial design and maybe some preliminary results.
Yeah. So basically, the question here was, do we randomize patients? And the problem is that patients are so ill that it's challenging to randomize patients. So what we did was had basically two parallel registries of FlowTriever for massive PE, high-risk PE, and then context arm for basically standard of care. And the reason that we did this also is that we did basically a retrospective data analysis in our group and looked at the kind of the mortality for massive PE and found that it was so high that you didn't need that many patients to make a difference.
Yep.
So the hope was that we could, with 100 patients or so, see a difference in mortality. And I think we did. We basically saw that we predicted, mortality in the 35-36% range for massive PE.
Yes.
And what we saw in the FlowTriever arm was, less than 3%.
That's remarkable. 50-ish patients. How many ended up using mechanical circulatory support?
There was 50 in the FlowTriever arm and about 60 in the context arm, and the MCS levels in both groups were relatively low. I think 4 or 5.
Yep.
But what we saw was that, in short, in the FlowTriever arm there was much less bleeding because we're not giving TPA to every patient. But in the context arm, the risk of bleed was substantial. There were a lot of bleeds both in the brain and in the access sites. And the mortality obviously was different as well. It was much worse as well.
Yeah. Now, as national PI, one of the national co-PIs of this study, you had your finger on the pulse of the sites that were enrolling. Mm-hmm. And what was your sense during the evolution of the study on how site PIs were reacting to what they were seeing in terms of these results real time?
I mean, yeah. So step one of that question is, how do you find the site PIs? Yeah. And I would say that one of the challenging things in PE care is that there's many devices. Mm-hmm. So if your device, uses device X, Y, or Z, and you have 10 or 12 providers, you have to train them up all on the newer devices. So what we did in FLAME was we basically only used sites that were doing a good amount of FlowTriever already, so that we knew that they had kind of essentially like a good door to balloon time, mm-hmm. essentially.
Yep.
Their access time was low, their time to procedure was low, their risk of groin complications was low, and I think that was the most important thing, was finding good sites that did that. But as you implied, I think that people saw what was happening and were very impressed and very engaged.
Jim, let me ask you this, and you don't have a crystal ball, but how do you see the results of this study shifting guidelines or standard of care practice going forward?
Yeah, we don't want to overstate anything. Mm-hmm. I mean, obviously it's a small number of patients, but as I said in the outset, it's working in high-risk massive PE is much more straightforward in a way than submassive because the mortality is so high. But the hope is that, look, there's questions with any study. Mm-hmm. But if you look at the numbers here and the dramatic decrease in mortality, I think it's very hard to argue that this drop from 35% to like 3% is not consequential. And I would hope that eventually this leads to changes in guidelines. Maybe we'll collect more data, maybe there'll be more studies, yada yada. But I think this should really be opening the doors to changes in how we treat PE.
Jim, thank you for spending some time today. Thank you for the scientific curiosity, and thank you for being a steward of this trial and helping us advance the field.